Well, thank you all for coming. I'm the chair of cardiothoracic surgery at Weill Cornell Medicine. These lectures are sponsored by the college in an effort to allow you to interact directly with the physicians at Weill Cornell Medicine who are providing the latest, greatest, up-to-date technology and advances in all fields. This is the third of 3 lectures sponsored by Weill Cornell Medicine. Tonight we're going to be talking about robotics and robotic medicine and how we're applying that throughout cardiovascular surgery, cancer surgery, urology, general surgery, and how that all applies to you and everyone else in the community. As you know, the hospital that we're affiliated with is New York Presbyterian. It's been the #1 hospital in New York for the last 16 years running, and we're trying to help them stay at that place. By far, we feel very committed to the institution. They do a lot to support us. Robotics is not inexpensive to the institution. The systems are extremely complicated. The software is complicated. Maintenance is complicated. So we're very privileged to have their support. Tonight, having been in the community here for the last 3 decades, I'm very privileged to introduce 6 of our physicians who are on the faculty at the medical school and at the hospital. They're going to discuss all the different ways that we use robotics to help take care of you. It's fascinating. There's no question that's off the charts. You can ask anything you like. And to moderate the session tonight, I have a gentleman I've known for quite some time, a medical correspondent, Emmy Award-winning medical correspondent for WCBS, Dr. Max Gomez. Thank you, sir. I'm going to go down here. Welcome, guys.
Thank you for coming. Let me come on all the way down here. Is this working? Oh, it is. Good. All right. I've been giving our folks some instruction here on how to use a microphone so that everybody can hear you. Welcome. This is going to be a really interesting night this evening, I believe anyway, because this is really the future of a lot of medicine, not just in surgery, but also, as we're going to hear, in rehabilitation medicine. Robots are the future. Don't worry about it. The doctors will still have a job. You're not going to put the doctors out of work. But let me start by introducing our panel. We've got a large panel here, so I'm going to use a cheat sheet here. And let's start out with first Che Guevara Afane from bariatric surgery, gastroenterology, but he's going to tell us a little bit. After I introduce everyone, we're going to bring them out, and they'll tell us a little bit about their particular interest in their work with robotics. All right. Let me go to my next cheat sheet here. Forgive me. T. Sloan Guy in cardiac surgery coming out. You guys can all come out all at the same time. We don't have to be that formal here. Jim Hu. Boy, I'm having a terrible time here. Bear with me. Yeah, I think I need a robot to hold this for me. This is what I need. Jeff Port, there we go. Douglas Scher, and Joel Stein, last but not least. So I'm going to ask each of our panelists, first of all, to just give us a little quick background about who they are and where they're coming from when it comes to robotics. The plan is I'll lead a little panel discussion here, hopefully informally, for about the next 40 minutes or so. Then we'll take some of the written questions from all of you. And based on my experience in doing some of these and taking written questions from people, there are a lot of frustrated physicians based on your handwriting out there in the audience. So, please try to write legibly. I got to read them up here on the fly. All right? Dr. Afani, why don't we start out with you, please?
Thanks, Dr. Gomez. First off, happy to be here. My name is Che Afana. I spent the last decade here in New York. I've been I trained at New York Presbyterian at Weill Cornell Medical College. Did all my residency and fellowship there and stayed on as faculty. And I've been doing robotic general surgery and robotic bariatric surgery here in the city.
What we commonly call obesity surgery, I guess.
Obesity surgery.
Okay, good. All right. Dr. Guy.
My name is Sloan Guy. I'm a cardiac surgeon, and I appreciate you guys having us here today. I have a focus on robotic mitral valve repair, doing heart surgery with a robotic system, which I've been doing since about 2002. I trained at the University of Pennsylvania and have a pretty diverse background, including 20 years in the military.
Very good. Dr. Who?
Hard to follow a military guy these days, right? So Jim Hugh, I'm from in urology, a professor of urologic oncology. Chances are you've lived in a city where I've either studied or worked. I did my medical school at Baylor in Houston, then trained at UCLA, was in Boston at Brigham and Women's, Harvard Medical School, got recruited back to UCLA, and now I'm, and of course, here at Weill Cornell. So interest, of course, is mostly in prostate cancer, kidney cancer, and the application of robotic surgery to those areas.
Great. Dr. Port?
Hi, Jeffrey Port. I'm a native New Yorker, been in the city now since 1987, trained at NYU, Sloan Kettering, and at Cornell. Had been at the New York Presbyterian Weill Cornell Center since 1998. My interest is in thoracic surgical oncology, which is the treatment of lung cancer, esophageal cancer, and occasionally the rare tumor called thymoma. Over the past 6 or 7 years, I've dedicated myself to understanding how robotics can fit into the treatment of these diseases.
Very good. Next up, Dr. Scher.
My name is Doug Scher. I'm a urologist, and I've been at New York Presbyterian Weill Cornell since 1996, a long time. And I started doing robotic surgery in 2002. At that point, it was predominantly prostate cancer surgery, and now we've extended robotic surgery in urology to include bladder cancer as well. And we have a lot of colleagues that are also doing robotic kidney surgery. So my practice is limited to simply urologic oncology.
My name is Joel Stein. I'm from Rehabilitation Medicine. I'm the token non-surgeon on the panel. My area of interest is mostly stroke and other neurologic rehabilitation, and we use robots in very different ways to assist people with their therapy and for other purposes to assist them with daily life. I've been at Weill Cornell since 2008, trained at Albert Einstein, and then at Columbia University.
Very good. All right, so let's start out with, let's come back to the very beginning, because I think my guess is that there's a lot of misconceptions about what robots can and can't do in surgery here. How did this all get started? I know, Dr. Guy, you coming from the military, you can tell by his haircut, this really started as a project, a lot of it through the military?
Sure. The original vision was that surgeons either taking care of battlefield patients or patients on Mars in outer space, literally, could get remote telesurgery. In other words, the surgeon would not be in the battlefield hospital or on Mars. They would be back home, and they would be able to, over the internet, basically operate on patients. That was the original vision, called telesurgery. And it all started in Menlo Park, California, at a place called SRI International, and there was a project that was funded by DARPA, which is a Defense Advanced Research Projects Agency, part of the Department of Defense, and NASA, to build this system. And it ultimately was found not to be all that useful for it, and having been in those battlefield hospitals, I can tell you it would not be useful in those environments in its current state. But about that time, laparoscopic surgery, small incision, non-robotic surgery was coming about, and somebody said, well, this might be very helpful because it would give us the same degrees of freedom with the instruments that we have with our own hand. And that's how the project got started.
Now let's be clear, and I'll throw this out to sort of all of you guys to see who wants to take it. This is not C-3PO or R2-D2 doing surgery, because we think of robots as something that looks like a human, walking around and doing whatever C-3PO used to do. This is very different. Can one of you describe what the typical surgical robot? We're talking, I guess, primarily Da Vinci, it's called. What does it look like? Can we give it a shot?
So, robotic surgery is what we call simply a master-slave relationship. So the robot does what you tell it to do. And as Dr. Guy had alluded to, this emanated from work in laparoscopic surgery. Laparoscopic instrumentation can basically only move in two directions. What's unique about this robotic platform, the intuitive system, is that it has wristed motion. And so it's essentially like doing open surgery just through very small incisions. But the robot itself is not doing the surgery. It's simply doing what the surgeon commands the robot to do.
So, Dr. Afani, tell me about that. How do you control the robot?
Sure. So the surgeon sits at a separate console that's away from the robot, and the robot is docked over the patient. Typically, that involves 4 different arms that the surgeon controls. One's usually a camera, and then there's 3 additional assistant arms.
But the surgeon is still in the operating room.
The surgeon is in the operating room next to the patient, sitting at the console, and it's a one-to-one motion. How you move your hand, the robot moves whatever instrument inside the patient. And so, in effect, just like Dr. Scher alluded to, you can control the exact same movements that you would do in an open surgery situation.
Dr. Stein, the robots you're talking about are really very different. Can you describe that for me and how they're useful in your field?
Sure. So there's broadly speaking 2 types of robots that we use in rehabilitation. The most common is essentially a robotic therapist. Repeated exercises, for example, doing the same reaching exercise with your arm, can be beneficial for people recovering from a neurologic injury like a stroke. But it gets boring for a therapist to do. So a robot can do it repeatedly over and over. You can put video games in it so the patient is interacting with the device, makes it more interesting, more fun, and presumably helps them recover more rapidly. The other, which you may have caught on YouTube perhaps, are wearable exoskeletal devices. These are Iron Man suits, if you will, for the lower half of your body that patients who are paraplegic can use to assist them with walking, even though they don't have motion in their legs. And this is a technology that is available. It's actually being used in the real world. It has some limitations, but it is very exciting.
You know, I've seen a number of them, and the patients, it makes such a world of difference for these patients to be able to get up and move, not just psychologically is a big deal, but also physiologically it makes a big difference in it. But it really is like Iron Man or RoboCop kind of a look. Dr. Hu, I think we talked about a lot of the early drive, if you will, with robotics came out of urology. Describe that for me. Why was urology sort of one of the first on board with the robots?
Sure. So no disrespect to Sloan Guy here. The former Intuitive CEO, Intuitive is the company that has a monopoly currently. He said, we shot for the heart but hit the prostate. And so we know that prostate cancer in the United States is very common, and it's controversial whether or not PSAs should be used to screen for it or whether prostate cancer in fact needs to be treated. I think there's questions about that today, but if you think early into the 2000s, certainly about 40,000 men were diagnosed with prostate cancer a year. I'm sorry, rather 230,000, and about 30,000 men died. And so if you think about upwards of 80 or 100,000 prostate cancer surgeries being done annually, it was kind of the ideal situation where you triangulate to a smaller organ inside the pelvis. And so therefore, a lot of the early robots that had less mobility, for instance, to do general surgery, had a lot of application for a very commonly diagnosed cancer at the time. And the wristed motion that Dr. Scher mentioned early made it conducive to nerve sparing as well as reconstructive surgery.
So, Dr. Port, the bullet ricocheted off the prostate, ended up in the thorax, I guess, at some point eventually. A couple of our panelists have talked about wristed motion. I'm not sure that that's clear what that is and why that's such a big advance and what the robot allows you to do.
Sure. So the natural evolution in thoracic surgery has been from open surgery, where we make an incision literally from stem to stern, from front to back, to provide exposure. The ribs are spread. You put your hands inside and you count on the dexterity of your hands to literally get around a vessel or around an air pipe. The natural evolution was to then make small keyholes, and through those keyholes to put instruments that essentially could go up or down or sideways, really in 2 directions. The robot is a big advance over that. The robot gives you now multiple degrees of freedoms. Like your own wrist, you can turn these instruments and you can facilitate dissection, and you can actually transect tissue and cauterize as if you had your hand inside the patient.
So it really is almost like having your hands inside the patient.
Absolutely. And in combination with amazing 10x high def, as well as with great video.
And I can speak to that. I actually test drove a robot inside a guy's chest. I didn't touch anything. I didn't violate any laws or anything, but I got a chance to. And how many of you remember the movie Fantastic Voyage? I know the guys remember Raquel Welch in that type. in that tight wetsuit or whatever, but it really is like taking a step inside the individual's chest or abdomen or wherever you are and kind of looking around, because it's high-def, three-dimensional, 3D video that you're looking at, and it really is pretty remarkable. But now let's talk about, these are not cheap machines. These are $1 million plus. Is that, I don't know what the current, what the going rate is for these.
Over 2 million.
2 million. Oh, all right. I guess I got a used one. Tell me, that's an expensive, I don't want to say toy, but it's an expensive machine. And early on, the criticism was that it was more of a marketing tool for the hospital than a true value for patients. What do you think about that?
I don't even think you touched on the fact that the maintenance costs are 6 figures. So, I don't think it's a marketing tool for the hospital. You know, laparoscopy, what they were talking about, where you made keyhole incisions and you moved up and down and left and right, was initially mocked and sort of thought of as, this is crazy. What are we doing? Standard of care should be open surgery. And I think what we're seeing slowly is the evolution of a lot more of the specialties accepting robotics as more of the standard approach for certain disease processes, specifically with the urologists. I mean, I think they really led the way, and now robotic prostatectomy is, I'm not sure if it's the gold standard, but I think it's probably the most common approach to treating prostate cancer at this time. In general surgery, what I do in bariatrics, weight loss surgery, it's still sort of an up-and-coming field, and you know, the full effect and benefits of the robot have yet to be elucidated. It hasn't really penetrated the entire market yet, and it's still sort of on the upswing. We're still in an exponential growth phase with general surgery, and weight loss surgery is still further behind. You know, less than 5% of bariatric surgeons in the country use a robot to do bariatric surgery, so we still have a long way to go, at least in my field, and so we are still trying to see what other benefits we can get from the current technology.
So, Dr. Schur, since this started in urology, what are the advantages to using a robot for prostate surgery, for example?
So, you know, I always tell patients, and I really do believe this, that it's far more important who does your surgery than how it's done. And I think with robotics, that's very much the case as well. I think there are some really, really good robotic surgeons around, and there's some really good open surgeons. But having said that, I think if your skill set is in robotics, I think there are some real advantages of the surgery. That probably the greatest advantage is the fact that you're visualizing things at a 12-fold magnification as compared to open surgery. And so, for example, in prostate surgery, you're sparing nerves. So these are the nerves that provide a man the ability to have normal sexual function. And these nerves are very, very small, very, very fragile. And so in robotic surgery, you're operating in effectively a bloodless field, so your ability to see is far greater than it is during open surgery. But more importantly, you're magnifying the planes, and so your ability to spare nerves, I think, is dramatically enhanced. The amount of blood we lose is far less, and I think recovery is a bit easier. So, you know, I think you can have a good surgery either way, but I think in the right hands, there are some real advantages for robotics, at least in prostate.
But early on, the data didn't necessarily indicate that robotics really gave you a better result. Has that changed?
Well, I think, again, it absolutely has shown that there's improvements in recovery. I think blood loss, hospital stay, et cetera. And I think now we're seeing, as the data matures, we are seeing improvements in return of sexual function, and actually we are seeing earlier returns of urinary control as well from some of the techniques that we're able to do robotically.
So if I can, I'll just comment on that real briefly. So you know, I don't want to do any chest pounding, but I actually did, when I was at the Brigham, the first Medicare study of robotic versus open surgery. This was published in 2009 in JAMA. And at that time, and so when you look at the Medicare population, it's a one-payer system, right? And so you can look at the claims, you can look at the complications, and there were less complications with robotic prostatectomy compared to open surgery, and a shorter length of stay, a lower risk of a stricture rate, and that was shown even during the early adoption. Meaning I'm glad you corrected me, Max. It means scar tissue where you reconstruct and sew the bladder back to the urethra. More recently, and I think you'll see this in the press as well in the next 1 to 2 months, is also the fact that people who have robotic surgery, at least for prostate cancer, which currently comprises 85% of prostate cancer surgeries, they also have a lower likelihood of a positive surgical margin, meaning cancer at the edge of the specimen is removed, and they have a lower likelihood of use of additional therapies. For instance, if surgery fails, you have to rely on radiation or hormone therapy. And so my suspicion is that certainly in prostate cancer, there's a tremendous learning curve. So I echo what Dr. Schur said earlier about the individual surgeon being important. But I think as these learning curves for each individual field and each individual specialty in surgery are overcome, you'll see universally some superior advantages of robotic surgery.
Yeah, let's talk about that learning curve a little bit too, but go ahead.
I'd like to give a personal anecdote that I think sort of highlights the differences between open surgery and robotics. About 2 months ago, my wife underwent a robotic hysterectomy. Now, she could have had an open surgery, and I suspect the long-term result of an open procedure versus the robotic procedure would have been the same, okay? However, she was home in less than 24 hours.
Wow.
And she was driving, 3 or 4 days later and fully functional within a week. Now, that simply would not be possible with open surgery. So on one hand, the critics can say, well, it's really the same because the ultimate results are the same, but that's really looking at it more from a doctor perspective as opposed to a patient or family member perspective, where that fast recovery really makes a difference.
So Dr. Porter, let's talk a little bit about the learning curve here, because again, I think initially, a robotic procedure versus an open procedure would take much longer to do?
Yeah, that's correct. You have specialized teams, so you have to have specialized nursing. So not only is it important to have a surgeon who's trained, but you have to train up your staff. Once you get comfortable with prepping the robot and making sure that it's sterile, the time gets cut down significantly. But we have now published at Cornell a recent paper where it looks like, in terms of operative time, complications, 50 cases for our specialty seems to be the right number of cases where the surgeon becomes facile enough with the platform to compete against other minimally invasive platforms in terms of time and in terms of efficiency.
One of the things that we heard from surgeons who were classically trained early on was, yeah, but what happens if everything goes to hell and you have to go from a robotic and convert it into an open procedure? Are these surgeons who now are being trained with laparoscopic surgery or robotic surgery, are they going to be able to do the same sort of procedure, particularly, say, in general surgery?
I think general surgery is more of a unique in that respect because the majority of our training, especially in residency, is based on laparoscopy. So our conversions are usually to go from robotic to laparoscopy first and then decide to go to open surgery. Robotics, like I said, hasn't penetrated general surgery much. There's 2 general surgeons at Cornell who routinely use the robot, and there's 45 other faculty members who don't. So it's not a large portion of your training at this time, and typically requires additional training.
But I think it's a very good point. I think just like you train for success, you train for the catastrophe. You have to go through those simulations with your team. We do it constantly. You have to know what to do, who's in charge, ultimately what everyone's role is, and that has to be trained, has to be simulated.
One of the areas that, and it's not exactly bariatric surgery, cancer surgery, colon surgery, do we see that? I know you guys aren't necessarily, any of you, directly colon surgeons, but are we seeing any advantages in robotic surgery for that kind of, say, for colon cancer, a colectomy?
So there is some literature that's supporting the ability to dissect out the lymph nodes a little bit better using the robot because of the better visualization.
You can see better.
You can see better, so you can get more of sort of the lymph node basins associated with it. I think one of the biggest pushes right now is in rectal cancer because it sort of fits the same mantra as prostate cancer and some of the gynecologic specialties because you're really just working in the pelvis in one place, and you can really maximize the benefits of the robot.
Oh, I was just going to add that so one of the things I think that may be a bit confusing here as well is that robotic surgery and laparoscopic are both minimally invasive. And so when you mentioned rectal surgery, there was a randomized trial. It was called the ROLAR study that compared open to laparoscopic rectal resections. And in that study, I think it just illustrates, at least in surgery, you know, we talk about these randomized trials where you flip a coin and someone has one type of surgery and another person has the other, okay? It's extremely difficult to do that in surgery because it's not like in medicine where you have a new medication and you're giving someone medication A or B, right? And so there was a randomized trial for robotic versus open surgery in Australia published in Lancet, which is a great international journal. And in fact, in that study, there was no difference in outcomes. But that had to do with the fact that you know, again, with prostate cancer surgery, I believe the learning curve is over 1,000 cases.
Wow.
And so, so if you have someone, you're comparing someone who's done 1,000 open surgeries to someone who's only done a couple of robotic surgeries, you're not going to see any benefits.
Let's talk a little bit, Dr. Stein, about benefits here. Are there any studies that have demonstrated that you're going to get different outcomes in rehabilitation settings with some of the robots you described?
Sure, it's a good question. So there are studies showing benefit. The magnitude of those are not necessarily as large as we'd like to see, and for that reason there's a lot of research, some of which I'm involved in trying to develop newer devices that are more effective. I think for the wearable exoskeletal systems, the ones used by paralyzed patients, there's no study you need to demonstrate that someone who couldn't walk before is now up and walking. That doesn't need a study.
Well, well that's true. But is it fair to say then that at least partially this is driven by the patient as opposed to the physician? I mean, Dr. Guy, you described your wife. I mean, I think that's a perfect example, no?
Yeah, well, let me give you another example. So I did a robotic case today, and it did take a little longer than an open case would take. Mm-hmm. So if I had done the patient with an open procedure today, I would have taken a saw and divided the breastplate, opened things up, and quite frankly, it would have been a heck of a lot easier day for me. Been a very, very easy enterprise, okay? Instead, I used a robot and did it endoscopically with just tiny incisions. And that patient likely will go home, days earlier than if I had, cracked their chest. And so really, yeah, my day was harder. It was more difficult. But at the end of the day, it's really not about me. It's about the patient. And the patient wants to go home early.
To that point, we look at national numbers in terms of patients who can qualify for minimally invasive surgery and thoracic surgery seem to plateau at about 40–50%. Why is that? Why aren't more patients who qualify going for these procedures? And it's technically challenging to sit by the patient's bedside sometimes and learn these new techniques. And we think the robot is going to facilitate this. We think the adoption rate is going to be higher. So comparing one minimally invasive platform versus another may not be the right metric. How many more patients can be done in a minimally invasive fashion? The robot probably is going to facilitate that.
Are we collecting our cards here? We're collecting the cards. We'll get to them. We'll get to the questions there.
I was just going to add one thing. So I think we all obviously here are champions of robotic surgery, but I mentioned minimally invasive surgery, and so I'm going to give you two examples. So, for instance, I also at UCLA did donor nephrectomies, taking out kidneys to give for transplantation purposes. Okay, and we did not do those robotically because the donors at UCLA would go home the next day with a laparoscopic procedure that would take an hour and a half. And so why add the additional cost of instrumentation when laparoscopic outcomes are that good? So you don't want to look at everything as a nail and you have a great hammer, okay? The other point that I would make, though, for kidney cancer surgery, for instance, and this has been shown, the hospitals that have a robot were more likely to do a partial nephrectomy, meaning you have a cancer of a particular kidney and you're able to just core out that cancer in a very blood supply-rich organ and save the rest of that kidney. So the advent and adoption of robotic surgery platforms led to greater use of nephron or kidney-sparing surgeries, and so that's another important distinction to make.
So I think as long as you started us down that road, let's talk about what's the appropriate patient selection. Who are the right candidates for robotic surgery versus regular laparoscopic surgery or an open procedure? That always tends to be the important part. You've got to do the proper patient selection. So who's the right candidate? Who wants to take a shot at that?
I think obviously that varies on the disease and the specialty, but I can comment on urology at least. But I think for the most part, most patients are candidates for robotic surgery. If you look at some specifics, this procedure, we have to put the ports inside the abdominal cavity, and so as a result, some patients that have had very significant prior abdominal surgery may have scar tissue inside that may preclude you from doing a robotic procedure. Other patients, particularly when we do robotic surgery in urology, we have to put the patient almost upside down where their head is all the way down, and some patients that are extremely overweight, we have trouble ventilating those patients, so they may not be optimal candidates for robotic surgery in urology.
What about cardiothoracic?
So in thoracic, I use the robot selectively. I think it's really important that we understand the robot's a tool. It's not an operation. If I do it robotically or not, my patients don't come to me and say I want it robotically. They want it done in the most skillful way and obviously the most oncologically sound. I've been using it for a tough location. So esophageal cancer, really wedged in behind the spine, the insufflation of the gas, the optics are great.
Insufflation of the gas.
So we use the CO2 as a way of gaining exposure.
Filling up the chest cavity. Right.
Behind the sternum, rare tumors, the thymus gland, very tough to get to. That saw that Guy was talking about, it's a wonderful exposure to do that, but it's tough to recover from. The robot really facilitates 3 small incisions taking out that gland. So tough exposure areas right now are the best utilization of the robot.
Good. How about, here's the question that maybe you don't want to answer. What are the downsides to using robots? Nothing only has upsides. What are some of the downsides here that you see in using robots in, let's say, in bariatric surgery?
Sure, I'll take this question. I think all of us can probably attest a bit to this, is that the setup for the room and the turnover for the room takes a little bit longer because now you are using another platform that you're going to use during the operation to get it set up, and you're going to undrape the robot when you finish an operation and sort of have to reset it up for the next case. So one of the downsides is probably the time between cases may take a little bit longer.
And that's an issue for the hospital, though, isn't it? Because you're not getting as many cases done per operating
Well, that's
room.
an issue for your next patient. I think it's
that
much
too.
for the surgeon and the patient to follow.
I think it's also important to realize if you're not careful, the training of our future surgeons can be impacted by the robot. Early on, with that learning curve, many of us are eager to do the robotic case in its entirety, be there for the entire case, obviously, and from start to finish, and it can impact the training of our residents. Now, the advent of a dual console, which is a second monitor for a surgeon to sit in and help and start to integrate that surgeon into the operation is incredibly important, but that's only been recently.
Dr. Hugh?
I would just add that, again, we're all technophiles, but we also know that healthcare is comprising a greater proportion of the gross domestic product. And so, again, with each one of these robotic systems being upwards of $2.5 million, sometimes at a hospital level, you're robbing Peter to pay Paul. So that $2.5 that's spent on the robot isn't spent on something else.
Price just went up $500,000 while we were
I'm
sitting
thinking
there.
of the new one, right? And so I would add that that's number one, to be cost conscious, and those are made by the hospital administrators and so forth. Number two, kind of similar, I think, to what Dr. Port said, is we all are also, at least in urology as early adopters, at a period where our trainees may not know how to do open surgery. And so it's almost like the open surgeon is the break in case of fire glass that needs to come out if there's a robotic failure, which is very rare. But one of the great things about, I think, the time that I trained, and certainly Dr. Scherer, is that he's a fantastic open surgeon. He's also a fantastic robotic surgeon. And so when you go to people like that, then obviously when in Rome, do as the Romans, right? But in this case, if you're skilled at both or laparoscopy, then you can offer what's best for the patient.
Dr. Guy, what's a downside for cardiac surgery?
Well, I think it adds a lot of complexity, particularly for the team. Cardiac surgery done with a robot requires a much greater degree of teamwork than regular heart surgery does. Some heart surgery operating rooms in the United States, not mine, but they'll be playing, rock and roll and everyone doing their own thing. That's really not possible with this operation. It requires a level of coordination that would be on par with an NFL football team. And so, for instance, when I arrived at Cornell about a year ago, despite the fact that I was doing a high volume of these procedures in Philadelphia previously, it took me 3 months to get the team at Cornell trained in terms of choreography and individual skill sets to support me doing that operation. And that does add, that adds some stress to the team. The flip side of that, though, is it builds a lot of camaraderie. I think it improves communication during regular heart surgery. And I think it's overall probably had a beneficial effect on our program beyond robotics. But it will be quite intimidating to, say, an old-fashioned heart surgeon who just really doesn't want to talk to anyone, doesn't want to communicate with anyone. It's, their way or the highway, and they just sort of come in and bark orders. That kind of personality will not be able to do this operation.
And I think that's actually a good point, that it's not just having a robot and having a surgeon who knows how to use a robot. It really is an entire team that is required to make it truly a valuable addition to all of this. Do we have our questions yet or no? We'll get to that. All right, we'll get to that. So what's driving this? What's going to increase the availability of robotics here? I mean, it sounds like at this point, it requires a fairly significant investment in personnel, training, maintenance, in the $2.5 million bucks. It'll be $3 million by the time we finish up here. There's only a certain number of places that are going to be able to do this, no?
Right. I think it's important to realize that the demographics really support more robotic adoption. We have an aging population. We have the addition now of multimodality therapy. That's a fancy way of saying chemotherapy, radiation, and surgery. Those patients look quite different when they come to the operating room. They're often already debilitated. The amount of scarring from the therapies can be quite challenging. Doing those patients minimally invasively really helps out. And so I think the robot is going to shine as we get these more complex patients, which is guaranteed given the demographics.
Well, I have a question for the audience. So how many people in this room Googled something today? Right? How many people in this room knew that Google was building a surgical robot? Yeah, I mean, it's incredible. Now, they're not the only ones. There's about 8 or 9 different companies, but I think that right now we're a little bit limited by having really only one multi-purpose robot from Intuitive Surgical, but there are a number of other companies that are now moving towards that, and I think one thing that will happen is more innovation, so more tools developing, and also I think the cost will ultimately come down when there's competition. Right now there's essentially a monopoly with one company, and as these other companies, Medtronic, Transenterix, there's several others, start building these robots, they start coming out to the public, we'll see an explosion, really a renaissance of robotic surgery taking place.
Wow. So Dr. Stein, same question to you then. What is going to allow more of these to be used in rehabilitation?
So cost is a big concern here as well. I mentioned the Ironman suit, if you will, the lower extremity devices. Those are about $75,000 to $100,000 per person, and it's very hard to get an insurance company to pay for that, even though it's of obvious benefit. Many of the other devices that are used in a hospital setting where you do exercises also quite expensive, $150,000, $200,000 for some of these. So that's limiting the availability.
And as long as you mention the cost, reimbursement, insurance reimbursement is becoming a bigger and bigger issue, of course. Is there an issue with reimbursement at this point? And how do we get over that or around that?
I mean, initially, and again, at least for prostate cancer surgery, when it was relatively new, a lot of insurance companies would deny a claim for robotic-assisted radical prostatectomy. Now that's changed significantly, I think, for most, at least, the urologic procedures. But I would imagine that, and when you look at how these things are billed, there's always an unlisted code. And so insurance companies, you may have already experienced, try to deny a lot of things. And so, so I think that's a potential issue with new procedures.
Have any of you others?
Yeah, so it's fascinating. If you do
specialty?
an open procedure to take out someone's lung, you get paid more, it's quicker, and you get paid more than if you do this robotically or minimally invasively on another platform.
Is that right? Really?
Across the board in most of the specialties, that's the case.
All right. That doesn't make sense. Although I'm a little, I'm a little put off by how easily he said when you take somebody's lung out. It's a little I felt a little queasy there. Let me take a step. Let's take a step back here, because I've got a question here that this is something where we probably could have used the one or two slides or pictures here. And the first question really is, I'm having trouble visualizing what exactly is inserted into the patient: a needle, microscopic knife, multiple devices. Which one of you can actually paint a word picture here of what it looks like? Because I've seen it, but it's not something most people have seen. Sort of what this looks like. It's this big multiple armed kind of octopus over the patient. Who can describe this for me?
Yeah, so it's essentially a tower that's very portable. It wheels in, and it has 4 arms, which have incredible dexterity. And through that, a port is placed. A port is just an entry point. Now these are down to 8 millimeters, 5 and 8 millimeters, so that's very small. I mean, we're talking about something that you can do quite a bit of sophisticated instrumentation through. So it's essentially a cart with 4 arms hanging over the patient that you then attach to a port of entry.
And each arm, though, as you said, is only a few millimeters.
5 to 8 millimeters, which is incredible, yeah.
Because people, you say arms, and people are, again, picturing something large getting pushed into a chest or an abdomen. These are really small.
And you can change out through each one of these things different instruments. So there's a whole slew or a portfolio of instruments that vary depending on the specialty.
I would just add that, for as an exercise, Dr. Guy mentioned earlier Google, and I would just extend that to YouTube. Early on, there was a nice representation of the fine movements that a surgical robot could do. They had the origami swan that the robot folded up, and they showed, I think it was either a penny or a dime right next to it. And so again, it just shows how fine the movements are and how precise.
Wow, that is impressive. We have seen multiple examples of hacking, cybersecurity issues. Are these robots secure?
Ours aren't hooked up to the internet because our IT folks didn't let us do that.
Which I think is a good thing. So you're not going to hack. What did we hear about?
They'd hack into the whole hospital system if it was connected to it. So you have to go through the hospital server. So I think bigger problem is not the robot, but all the patient information through the hospital system.
Risk of failure of the robot? I mean, computers, electronics, mechanical things fail.
It's extremely low. I mean, it's one of the most reliable. The Da Vinci is one of the most reliable devices that I've ever seen. And I've never personally had to convert in the middle of an operation because of failure of the device. It has happened, but it's extremely rare. And the good news is that we train for that. We always have a backup plan. All of us are very competent at either other minimally invasive techniques or non-robotic techniques, and we can switch game plans in a heartbeat were that to happen. But it's extremely rare. It's a very highly reliable instrument.
Yeah, in this digital age, believe it or not, there are analog backups, so everything's manual. So you can essentially turn a key and release a robot arm or instrument, and we train for that, and it's really pretty seamless.
The other thing I was going to add is that part of the preparation in the room prior to the operation is to do a check. So much in the way that when you guys jump on an airplane and fly someplace, the pilot goes through a checklist. We go through a checklist, and that checklist includes checking the software and hardware of the robot to make sure it's functioning properly.
There goes that question. Okay. Dr. Stein, are there similar things there? Because again, we've seen movies where the person wearing the robotic suit develops a mind of its own and goes crazy.
Sure, that's not been an issue in terms of hacking. Again, these are devices that are typically not connected to the internet, and reliability has been good, safety's been good. It's been the primary design consideration with all these devices, surgical and non-surgical, is really safety, because everybody knows if you mess that up, there's no going back.
So do you think the old style is the term here, the old style, let's call it traditional, open surgery, will eventually become obsolete? Or will there always be room or a place for traditional open surgery? Or is,
I
that,
can
is a
answer.
robot
I think the
gonna take
answer
it
is yes. There will always be a role for it, and it has to do with the priorities of a good surgeon and their team. And the number one priority is to get a patient safely through the operation. And that's the number one priority. And the second priority, really is to solve their problem, whatever it is, whether it be a prostate cancer or a mitral valve, leaky mitral valve, or lung cancer, or what have you. And only after then is our priority minimally invasive. So, at least in my case, I will not hesitate to convert to an open procedure when a minimally invasive procedure is not the way to go. Some of the more stressful conversations I have in the office are when patients come to me wanting a minimally invasive approach, and they're really not good candidates for it because it violates those priorities of mine. And I have to sort of have that exact conversation with them and said, well, the most important thing is for you to survive this with minimal complications, solve your problem, and in your case, a minimally invasive approach is not the way to go. It requires a lot more discussion with the patients when you're into minimally invasive techniques.
And I presume that when they sign their consent, that it includes the possibility that the procedure may be converted to an open procedure.
Every single time.
Yeah. So Dr. Schur, will these robots ever become autonomous, that they'll do the surgery?
It's an interesting question. Jeff and I were discussing this prior to the meeting. I think, artificial intelligence and autonomous surgery, exists in some capacities now, and I think it's going to grow, certainly in terms of image fusion surgery. So there are some examples, and I think Jeff can certainly talk about this as well, but, where you can determine a point on a CAT scan where a tumor may be located, and then setting in motion, similar how cars can drive automatically now as well, but you could find the tumor, biopsy the tumor, and ultimately probably take the tumor out. So I think autonomous surgery is certainly on the horizon. Whether it's going to be in my generation, I think it probably will, and I think it's going to have a growing role.
Right, so it may not be the classic image of the robot actually cutting and taking something out, but as Doug had just alluded to, we have challenges in the operating room of finding very small things and doing complex operations once we find them. I think the robot and the computers in the system will have an advantage over localizing some of these lesions. So we just talked about eventually a robot may guide you to an area where the surgeon then takes over, but there are different aspects of the operation that I don't think we have to fear, but I think the robot will enhance ultimately getting to that particular location.
I'll just, if I may,
yes,
Max, add one thing, which is there's something nice as well about the robot. Well, the platform, although you can also do this with laparoscopic surgery, the trade name that they use is firefly or fluorescence, meaning that you can actually have the anesthesiologist inject a compound. The acronym is ICG, and you have an infrared camera that you can then toggle over. And so for certain procedures, for instance, partial nephrectomies, sometimes you have two arteries or blood supplies that feed the kidney, and so then you don't want to kind of get caught with your pants down, if you will, and not know where both of those arteries are before you cut out the tumor. And there's other fields that have injected this, for instance, gynecology up the ureters, the tubes that connect the bladder to the kidney, to visualize that to avoid accidental injury. So that is a nice feature of robotic surgery that's very difficult to duplicate in other surgeries, and actually Intuitive Surgical, I think, is investing heavily in fusing preoperative images onto their robotic platform.
Dr. Port, I think before you were describing to us when we were back in the conference room, the sort of almost like a GPS system for getting to certain tumors within the lung.
So right now we're empowered with fancy bronchoscopes, these scopes that go down the air pipe. Excuse me, if you want to navigate out to a very small nodule, there are now systems available where you can use almost a GPS guidance system where you can get a pathway and you follow the arrow very simply out to the nodule. It can be a little cumbersome. It requires some assistance in how you hold things, and slight variations really can affect how you successfully biopsy something. That's a perfect example where a robot with a stable platform sitting at the mouth could essentially guide based on its computer imaging to that lesion. And you could override it if there was a problem, but ultimately one can envision where this navigation, this driving like an autopilot in your Tesla or in your car, which is coming shortly, will be a part of endoscopy, of going through your mouth or through other areas of your intestine using the overlay CAT scan to help guide you there.
Wow. So physicians are often accused of doing things that will benefit them financially rather than benefit the patient.
We just told you about the reimbursement, didn't we?
Well, that's that's where I'm going. What drives you guys to do something that is counterproductive to your bank account, if you will? The reimbursement, it's harder to do, at least initially. It takes longer to do, and your reimbursement is lower. Why do you do it?
Patients have better outcomes. They go home sooner. They have less pain.
I think also there's the author Daniel Pink. He has that book Drive, right? And he mentioned one of the, so I think two of the things that people do behind motivation is mastery of their own field, right, and autonomy. And so I think if you're a good surgeon, you hopefully accumulate more influence. I think patient-centered care, of course, is very important, but I think that ultimately you want to be the best in your field and offer the best thing to the patient.
We don't want to deal in futures, but it's hard not to get excited when you start imagining what the platform is capable of doing. So when you share some of the projects that are going on from Google and from Medtronic and from Intuitive, it's pretty amazing to think about what is possible in terms of even replacing some aspects of surgery with local ablation therapies where you can freeze or burn or early cancers and identify these things really early. So it sky's the limit when you start talking about the addition of some of these robotic and computer platforms.
It's also expensive for the hospital. Have you had any pushback or resistance from the hospital in terms of being able to do as much as you think you should be able to do with the robot? It's a hospital
it's
giving you a
interesting
hard time.
the hospital obviously thinks about cost, right? And
They should.
so we did a study a while back looking at bladder cancer, which is, the most expensive cancer to care for out of all the cancers. And taking out someone's bladder is a very costly surgery. And so when you add robotics to it, it becomes even more costly. So the question is, why would the hospital want you to do this? And what actually transpires is that complications go down. And complications are incredibly costly to deal with. And so I think if you look forward, and the hospital has become somewhat forward-thinking in this, is that by diminishing complications, diminishing readmissions to the hospital, I think your costs can go down astronomically. And I think that's where robotics has its largest benefit. Although the initial material costs are high, I think the long-term costs have shrunk.
They need to look at the bigger picture.
Yeah, when I first started, and that's not that long ago, we had a DRG, which is a reimbursement a code for lung cancer, which was 12 days. So you could keep your patient in the hospital for 12 days. We now have a median length of stay with robotics and minimally invasive platforms of 3.1 days. And that's only in 15 to 16 years.
Wow. So I want to wrap this up, but what I always like to do whenever I do a panel like this is I want to ask our panelists, take 1 minute, because I know how this goes sometimes. Give me a little, just the take-home message that you want people to remember, either where the future is, what you want them to know or remember about what we've talked about here today. And Dr. Stein, I'm going to give you first shot here, please.
Sure. So I think that it's likely over time your visits to your physical therapist may involve more technology, more robotics, and I think that will be a good thing. Hopefully some of these devices will also ultimately end up in the home, and people will be doing exercises on their own with the assistance of these devices and add efficiency and also convenience. So I think that's in everyone's future. We're all going to need rehab at some point, and sooner or later, we all do. And for that reason, I think knowing these technologies are coming, I think is a helpful thing.
Good deal. Dr. Scher?
So I think what's really refreshing is we've gone beyond the hype of robotics. And so back in the early 2000s, robotic surgery was a really patient-driven, almost frenzy. And I think now what robotic surgery has become is really a tool. And as much as the way you'd use an EKG to look at your heart or a chest X-ray to look at your lungs, I think robotic surgery has really become part of the armamentarium that surgeons use now to treat a variety of different diseases. And I think it's clearly here to stay. The technology is only improving. And I think what's more important, the training and experience on it has really dramatically improved as well. So I think from generations to come, robotic surgery will certainly have or become a piece of the puzzle.
Dr. Poor?
Yeah, I would say that robotics is a tool. It's one of the many tools in your tool belt, and that patients shouldn't become wedded to one particular platform. Picking your surgeon is incredibly important. Picking your hospital is incredibly important. And then at that point, you have to understand each person is an individual, and the therapy has to be custom tailored. If you don't get the answer you want, that you're going to be done minimally invasive at home in a day or two, it may be that you're not appropriate for that. And that the robot essentially is a great tool, but it's just that. It's an extension of the surgeon, and the surgeon's judgment is still incredibly important. And that for the right person, it's a tremendous step forward.
Dr. Who?
I think I would just take a step back and, you know, a very common question to me is beyond, say, robotic surgery is, you know, how do you, you know, it's New York and someone will say to me, well, tell me why I should come see you versus someone else. You know, it's a very aggressive mentality. And so I guess I can say that from where I've been. But I would just add that, you know, everyone on this panel, fortunately, is in an academic field. Sometimes there's a question, well, are you doing my surgery because we're in an academic setting? But that's where innovation happens. I also tell them, you know, look online, and you know, sometimes people go to the websites and there's a lure of, you know, these claims that can be made, oftentimes without substance. And so what you can do is look and see if your potential surgeon has published a technique, a video, or, you know, a description of what they're doing, because that's how, if I had, for instance, a cardiothoracic surgery, I would be looking at this guy or Dr. Girardi because they're experts that have published in a certain technique.
Good point. Dr. Guy?
Well, I would take a step back and look at robotics in general, not just medical or surgical robotics. I think robotics is going to explode in the next 10 or 20 years, much in the way, you know, the internet has in the last 20 or 30 years. You know, I remember buying the internet in a box,
Yeah.
you know, like it was yesterday. And now look what we have. And, you know, robotics is sort of the natural extension between the electronic world, which we are now all part of, and the real world, which we're certainly part of. Robotics is really a connection of the two. I think that's why companies like Google have gotten into it. And today it's a Roomba that sort of sweeps your floor. Tomorrow I think it's going to be a humanoid robot that's going to, you know, hang out with you in your house and do things for you. And I think in surgery in particular there's going to be really an explosion of robotic technology. Some of it will be autonomous eventually, or enhanced you know, surgical capability. But you know, if I were a young person going into engineering, robotics would be a pretty good field to get into, I would think.
Cool. Dr. Fanick?
Yep. Not too much to add here since the panel's all given us their take. But I think, from my take on it, is that we're going to be able to do more complicated revisional procedures as the population continues to age. We can do more complicated things and probably avoid some of those more traditional open incisions as the technology continues to mature.
And my take-home message for you is, building on what our entire panel really has said, is don't listen to Dr. Google necessarily, because Dr. Google may or may not know what your individual case is all about. Consider the source. When you go and look on the internet and see who's doing what, the thing, you always have to consider the source. Dr. Quackenbush is going to have a website that looks every bit as impressive and authoritative as Weill Cornell Medicine. But Dr. Quackenbush may not have published, may not be know what he's really doing here. So figure out, you're not the one who's necessarily the best person to choose whether you should be done robotically, laparoscopically, or an open procedure or whatever. Go to the best physicians, surgeons that you can find, and let them guide you. And it might be robotic, and in the future more and more of it will be robotic, but that's not necessarily the best way, although that's the way we're all going, right? I want to thank our panel. It was really, I think, interesting and stimulating.